Hello, everyone, and welcome to the Babies in Common Show. I'm Jeanette.
And I'm Melissa. Welcome, listeners. We have another great show for you today. As a reminder, anything said on this show is not to be taken as medical advice. Please consult your own care providers and visit babiesincommon.com/disclaimer for more information.
So today is Wednesday, July 29th, 2020, and we're going to be discussing what may be a scandalous title, but we hope it's empowering and we hope it doesn't have to be used. The concept doesn't have to be used very often at all, but firing your maternity care provider during your pregnancy, even very, very late in your pregnancy. So hot topic. Yeah. So
yes. And
really
I came
fun.
up with the title, which I thought was pretty witty. It's not me, it's you.
Yes.
So, I mean, is this even possible? Can you switch maternity care providers in your pregnancy, even in your third trimester, even the day before you have a baby? It is possible. It can be done because we have somebody here that did it and lived to tell the tale. Our guest today is Emily Garcia Sega. Emily earned a doctoral degree in chemistry from the University of California, San Diego in 2011, and is currently an associate professor of chemistry at Western New England University in Springfield, Massachusetts. In 2016, at 37 weeks pregnant with her second child, Emily fired her OBGYN care team and crossed state lines to find a provider who would help her achieve the evidence-based birth experience that she desired. She currently lives with her husband and two young children in Connecticut, and she also happens to be one of my very best friends. In fact, I was honored to support her during her 2016 labor and birth experience, which we will be discussing today, as her, what I like to call, doula nurse.
Awesome. Well, thank you for being here today, Emily. This is going to be exciting. I'm always curious how these things roll out. So yeah.
Thanks so much for having me.
Yeah. Thanks for saying yes. This is a very private topic, really. It's sort of like you're being a badass, but at the same time, it's a very personal thing. It's about how you're using your body to give birth. So.
Absolutely. Yeah. We always appreciate when people will come on and tell firsthand stories because I feel like that's a wonderful way to learn about the process and your options as a pregnant person that might be listening. So thank you.
I'm hoping I can help someone advocate for themselves as well.
Excellent. So before we talk about your 2016 labor and birth experience, let's back up to your first pregnancy with your daughter, Claire, who was born in February 2013. Can you tell us a little bit about what birth experience you were hoping for, where you were planning to give birth, and how you prepared to give birth and how things went?
Sure. I was always, so I'm a scientist, so I'm a researcher, and I dove into researching birth plans and everything like a true researcher. I had hoped for an unmedicated birth, and I knew I wanted to have my child at in a hospital setting. So I took a traditional childbirth class, and I also took a baby's movement for birth class. And when I was going through that stuff and reading lots of books and doing research, I decided I also wanted, for me and my partner, to have a doula. So we also hired a doula. And I ended up having a natural chemical-free birth, unmedicated birth. And I labored in the water. At the hospital, there was one labor tub that they had, and I tried my best to reserve it as soon as I possibly could. However, I mostly labored at home. I labored at home throughout the night, and then in mid-morning, my water broke and things really started to progress. And so that's when I went to the hospital. And so even though I got to use the water, they didn't allow me to fully fill the tub even because
Lord.
I was in a good phase of labor at that point. So I had a really good experience with my first birth.
Okay.
And
so did you call them to say, I think I'm coming in, please can I have the tub room? Because I often tell people to do that. Is that how that worked out for you?
Yes, and at that point they had someone in there in the early morning hours, but luckily they were, I guess, able to transfer them to a different room because they knew I had been talking about how much I had wanted that room, and so luckily they weren't using it, so they made it available, which was really good.
Sweet.
Made me
Awesome.
feel really um, more comfortable, I think, because that was part of my plan. But
Yeah.
even if it hadn't, it would have been okay.
And
Yeah, and at the
so,
hospital that you gave birth at, I know because I worked there in nursing school, they sometimes do LDRP for vaginal deliveries, meaning you labor, deliver, recover, and then kind of stay postpartum in that room. And so it was really excellent of you to call ahead like that, because what probably happened was that person delivered and there was plenty of labor rooms available, so there wasn't really a rush to get her to a postpartum room. And so by doing that, you really, stack the cards in your favor to get that room, because they probably, it's not, I don't want to give anybody the impression that you called so they like took someone out of the tub and like put her in another room.
No.
this woman Emily has been talking about this for months. You really need to go.
You need to get out of this tub, okay? Emily's coming. So, that was a good thing. That was definitely a good way to advocate.
Yeah. So you had this awesome birth, the one you wanted for your first baby. And so what did you decide to do with your second? I would assume you would plan the same thing.
Yes, I was hoping to do the same thing, have a nice smooth delivery, possibly even smoother because I had the first experience. I kind of thought I knew not every situation was going to be the same, of course, but I was hoping that I could have a repeat of a positive birth experience.
Yeah. And I mean, honestly, most people do have like a quicker labor for their second. Most people don't get the curveball labor until it's their third baby, but this pregnancy did throw you a curveball, didn't it? Can you tell us about when you first found out your son was breech and how you felt about that?
Sure. I was, I think, right around 28 weeks pregnant, and they told me that my baby was breech, and it was very nonchalantly, I would say. I didn't really they didn't seem concerned at all. And
when you say these are midwives you're seeing at the time?
Oh, yes. Yep.
Okay.
So I went to a nurse midwife practice. And so they just, I think, mentioned that most babies still have some time to turn. And so me being the researcher, I went home and looked at it, looked up the statistics, and called my good friend Melissa, who was also
which
my
I basically, it's so funny that you said, I said I offered to be your doula nurse. I feel badly because I kind of was like, I can be your doula. I think I gave you a choice. But when you told me you were pregnant, you were like, I was like, I can be your doula. I just was so excited. And so what was funny though, was then 3 months later, I got pregnant. So I was your doula while I was also very, very pregnant. And so It was fun to go through that experience together because, we both had a baby before and we were both pregnant with our second. And then you call me and you're like, he's breech. This wasn't in the plan.
Yes, it was not in the plan.
And I think that I also reassured you that there still is time for the baby to turn, but I also had given you some resources since you were a researcher and you did want to be proactive about maybe things to do to help the baby turn. Do you remember any of the things that we had talked about or that you decided to do?
Absolutely. So spinning babies was a big part of my life during that time. Lots of exercises, laying on an ironing board upside down, doing the gentle heating pad in my pelvis, and I remember putting like cold peas on the top of my stomach to try and get the baby to turn.
I love that one because we assume that babies don't like cold and that cold is strong enough to reach them.
Yeah, right.
Yeah. They're like nice and incubated in there.
The blood flowing in your body doesn't have the force field to prevent that cold from getting through. I mean, who knows? Maybe the baby's like, oh, thank goodness it was cold. I like that.
Yeah, we don't know. Maybe they're like, get me out of this sauna,
Right. Yeah.
And me and my daughter, who was 3 at the time, would do a lot of like the cat cow moves and stuff like that. And then when my baby was still breech, a few weeks later, I got more serious. I did just about anything I possibly could. Melissa had told me about chiropractor. I went and saw a chiropractor. I did acupuncture, the moxibustion stick, and then my nurse midwives mentioned version. So those are all things that.
So they mention it, and then how do they describe that? Because I've had people, I used to be a doula, and some people have been like, oh, that sounds so scary. I can't even wrap my head around, like, there's no way I'm doing that. It sounds horrible. And others are like, all right, sure, let's try that. So, like, what was your initial thought to that when they mentioned
how
it?
did they
make it sound
describe it to
scary,
you?
or did they make it sound like something that works really, it works often, so we love to try it? Like, what was kind of the mood of that conversation?
I think because I had my first child with them as well, they knew how much I wanted an unmedicated birth and to try and have a vaginal delivery. And so they definitely told me in a positive way that it was an option, but they did, of course, cautiously tell me that because they weren't, it's not a guarantee that it works, right? So they mentioned, just the physical turning of the baby, and they weren't going to be able to do it, but they have partners at the hospital that would step in and do that.
Because this particular midwife group delivered at a large teaching hospital. So as is often the case, versions, the standard of care is that they are performed in a hospital. And if there's anybody here that is listening and interested in learning more about versions, we actually did a really excellent episode of this podcast on versions. I believe it was episode 11. I think it was episode 11 was about versions, and episode 12 was about having a positive cesarean birth experience. So definitely check that out, because we interviewed Kate Damon, who's a midwife in the Cambridge area. And she talked all about all the things Emily was talking about, all the things she tried to turn her breech baby. And we also talk about, I am, look at how I am just so good. She not only talks about all the things that Emily spoke about, but we also talk about the research behind it and the statistics of safety and success rates and things like that. So be sure to check out that episode if you're listening and interested in learning more. So this version was brought up. For those that don't know what that is, that's when you generally go to a hospital and an OB provider. Sometimes a midwife will assist, but generally it's an obstetrician that uses their hands to try to turn the baby into a somersault to flip head down by touching the outside of your abdomen. And this is often with ultrasound guidance. They try to nudge the baby and check the position with the ultrasound as they're going. And so they bring up this version. And I do remember, you called me up and was like, what do I think about this? And do you remember anything about like our conversation or what you learned about version, or what you were nervous about, or what you were interested in, anything like that?
Of course, yeah. I remember being nervous for the safety of the baby. I was nervous about the pain that it would cause, and me and possibly the baby. I had no idea at that point. I also remember you walking me through kind of what happens in the process, how the doctor or the doctor and assistant sometimes kind of first check out through ultrasound about where the baby's positioning is, check the heartbeat constantly, and then manually, physically kind of push to turn the baby. And so from there, I remember you also sent me lots of good resources, some articles that talked about the data behind the version.
I think that's important because with everything comes risk. And there's a difference between relative risk and absolute risk. So, somebody might say something, let's say that you have double the chance of all your hair falling out if you drink this drink versus that drink. But the absolute risk that your hair is going to fall out is a 1 in 1 million chance, right? So doubling that risk, which would be the absolute risk, would be a 2 in 1 million chance, right? So it's important when people talk about risk, we understand the difference between relative risk and absolute risk. It's important that we understand that there are not only risks to version, but also risks to repeat cesarean I meant primary cesarean, just cesarean in general, risks to mom and baby for increased rates of, bleeding and blood clots and infection. And so what I like our listeners to know is that sometimes, many times providers who work within the standard American maternity model of care have a 15-minute appointment with you. And so they don't, even if they are the most compassionate, most pro version, most pro whatever, they don't necessarily have the luxury of time to go over any of this with you. And while a doula is not a medical professional and they are not going to give you medical advice, and in the capacity that we working together, Emily, I was not giving you medical advice. I was acting as a doula, a friend, a knowledgeable friend because I was a nurse, but just simply saying like, here is some literature for you to check out about risks to all of these different things. And yes, there are could be changes in the baby's heart rate, but they're going to monitor it the whole time and walking you through the procedure. And sometimes what we think is in our brain, right, when we hear about something is not really what it plays out, how it plays out in real life. So
the other thing about that too is like the success rate of versions, and there's statistics out there, but also what's the success rate of the person who plans to do your version?
Sure.
Which is also an issue. And I feel like there's many people I've spoken to. I was present at 2 versions, which was interesting, being the same person, so that was interesting. But just the intensity that somebody wants to help you versus someone who's like, well, I can do versions, but I don't find them very successful, because maybe they don't really care to learn how to do them well. Maybe they don't really feel like they're successful. Maybe they do them, but they don't feel like they're that successful most of the time because their skills are lower. I don't know, but that's a whole other thing. And where do you even get that? It's really more of a reputation, right? So did you ask your midwives, like, who's the best person? Or was there only like one person in that hospital at the time? Like, what's the story on that?
That's a great question. I believe I was told that I just got whoever was on that day.
Right.
At that point, they wanted to schedule me somewhat soon. But that was also an interesting thing, was the timing, because they automatically assumed that it was going to be a C-section. There was really a talk about aversion, but more about the C-section that was going to happen after. So that wasn't a very positive.
even the midwives were talking like that.
They were preparing me for the possibility of a C-section, and of course that's a possibility as part of what happens if a complication happens with the version, but also if it was unsuccessful. So that they must not have had a high success rate.
Sure. I mean, that's very true. Maybe that like they knew who was there, and that, didn't, that's so interesting the way that somebody describes it. Because if you talk to an OB provider or a midwife provider about it, and they're like, oh yeah, I mean, 50%. I mean, I've worked with a number of clinicians that have a 50% version success rate. And that's pretty awesome. I mean, some people might be like, well, that's 1 and 2, but there are people who have like a 0% success rate with versions. Like they don't really try that many and they don't really try that hard. And I've been to quite a few versions, and some doctors really feel for the baby, really try to figure out which way the baby's going to turn, really, make sure the mom is relaxed, are really, like, you can even see like they're closing their eyes and their brain is kind of working with their fingertips to try to figure out how to turn this baby. And then there are some doctors that are like, okay, I'll be out in 10 minutes, set up the OR. So, definitely, it can be telling the way people counsel you about these things, is if they are willing to make it work, or if they know. What I ended up giving you actually was something called a printout from Up to Date. So up to date is what is, and this is important for the next part of the story. Up to date is what clinicians utilize to research best practice for like literally anything. So let's say you are an ER doctor. You can't remember everything. Nobody can remember everything. And someone comes in and they were bit by a raccoon. Well, you probably haven't had anybody bit by a raccoon since residency. So what do? You go to Up to Date and you look up, what do you do if someone's bit by a raccoon? And it says like, this is the vaccine you need to give them. This is the antibiotic you need to give them, blah, blah, blah,
I
blah, blah,
love these
right?
ideas you come up with.
So it's funny because I actually have a friend
Who was bit by a raccoon?
Yeah, she's a vet, and she was bit by she wasn't bit by a raccoon, but I think she was bit by a dog that wasn't vaccinated, and she was a vet, and so she had to go to the hospital, and they were like, we don't know what to do if you're bit by a dog that wasn't vaccinated. She's like, looking Up to Date, like she's like, even I know that. So anyway, right? So I printed off this article and sent it to you of all about versions. And it was what research was out there on versions, how successful they are, what techniques work. And in this article, one of the things I remember was that one of your biggest concerns was that you didn't feel like you would be able to relax your belly enough to let them really manipulate because you really wanted them to try their best. And I was being honest with you when I said, it can be quite uncomfortable, sometimes quite painful to have somebody pushing your baby inside of you. And some women do really well with that. They just kind of go into like a hypnotic state and they just, deal with it. Some people benefit from a little bit of morphine or maybe like like a uterus muscle relaxant called terbutaline. And I said, I had even had some people get an epidural for the version procedure, which was an interesting conversation because as we've learned, Emily, you were planning for, hoping for, and already had achieved an unmedicated vaginal delivery. So you're like, wait a second, why would I get an epidural? I'm trying to avoid one altogether. Do you remember how I framed it to you?
I think you said something along the lines of, well, the version could be the thing that gets you the natural birth that you want, and having the epidural might, statistically, it can increase my chances of being able to have that vaginal birth.
Yeah, exactly. Because it's interesting to be like, wait a second, why would I have an epidural for aversion if I don't even want an epidural for labor? But as I've counseled many expectant parents, aversion, the pain of aversion is not the same thing as the pain of labor, right? The pain of aversion is a procedure, just like, any other painful procedure. Most people want to be properly medicated or anesthetized for that. So that's one thing, that the labor pain is different. It's not a pain that something is wrong. When someone's pushing your baby under your rib cage, that can be quite painful. But secondly, having an epidural in labor isn't just about the risks of getting an epidural, of which there are. But the risks of getting an epidural are very, very rare, epidural wise, meaning the risk
just for the epidural.
Right, just for the epidural. It's the most common thing that could happen is a 1 to 2% chance of a spinal headache. Other than that, things like, infection and nerve damage are exceedingly uncommon. The reason why many people want to avoid an epidural is mostly because they don't want the epidural to affect at a greater risk of having major abdominal surgery. So when I kind of framed it like that, you were like, that's interesting. That is, I do desire a vaginal delivery and I do desire avoiding on major abdominal surgery. So if an epidural is going to help me get that, I was like, would you accept an epidural if you had to have like liver surgery? And you were like, well, yeah, of course I would. That would be a procedure, right? So, so you scheduled a version. You were armed with, not just something from the internet. You were armed with literally what clinicians use to guide their practice.
I've gone to up to date before, but it's been a while, so I'd forgotten. There's actually a subscriber rate for patients, and they say patients and caregivers. So it looks like for a week it's like $20. So if there was somebody who was taking care of someone in their family or friend that had an issue, or you're a patient yourself and you're like, oh, they're talking about this, you can go for $20 and like look up everything you want for a week. So that's a nice option. So it's not something that you have to spend a lot of money on.
Yeah, because typically this is something that universities and hospitals buy, like the corporate, like academic package of, so that all of their clinicians can use it. It's exceedingly expensive. That's a good point, Jeanette. The other thing I recommend to people is either going to evidencebasedbirth.com, which is a fantastic resource for patients, because Rebecca Decker from Evidence Based Birth basically takes, she does peer-reviewed literature reviews and
all
makes
over
that
the
available to the
world.
public all over. Yeah. So,
And puts
so
it
she
in such
basically
a
is
good
like
way too. Like
very
makes
easy
it
to understand,
very
patient-friendly
understandable.
format.
Yeah.
Which I think is sometimes easier for people to kind of digest than a 65-page article on version. She has like a 1-page article on version. The other thing too, though,
we constantly are doing that, aren't we? The other thing,
I know.
the other thing. Go ahead, Melissa.
That's the problem. I was gonna say the other thing is that I've told people you can ask your clinician to print off something on UpToDate for you. So you can say, whatever it may be, whether you're pregnant or they want you to get a cardiac ablation. You can be, hey, can you print off the UpToDate article on cardiac ablation for me? If you really want to know the nitty gritty. In UpToDate, there's 2 things you can print. One is the patient education pamphlet, which is going to be, easier to digest. But if you really want the clinician one, they can print it off with all the citations if you're, kind of a medical geek. So
what I was going to say too, in addition to that, is that as a person who is also sometimes a patient, we go into the world of medicine thinking, well, of course our care providers are going to be doing all the evidence-based practice. Of course they're going to be up to date on what they're doing. Of course they're going to know this. Why wouldn't they treat me in the utmost? Why would they still be employed if they weren't doing evidence-based practice? And that's just the situation. And I don't know every other profession, but from what I understand, and Melissa, I've seen it from a doula and childbirth educator and lactation consultant side, but as a nurse who's worked within obstetrics, and then we all have friends who are physicians and nurses and nurse practitioners and midwives in medical practice. From what I understand, obstetrics is the least standardized in practice.
Oh, absolutely.
And so your care provider in the obstetrics world, midwife or doctor, is not always, depending on their personality and their desires and where they practice, and there's so many factors that
the
go
culture
into
of the hospital environment that they
may
practice
want to do something, but their hospital says not to do it that way. It's so political sometimes. And so they may not be doing what's evidence-based. Plus, everything I have heard, and I've seen articles about this by really reputable people, is that you can have the American College, is it college now or Congress? I always forget. American
Congress, I think, technically.
American Congress of Obstetricians and Gynecologists come out with a new guideline that says, do not do this standard anymore. Do not do this to your patients anymore.
Do not cut routine episiotomies on everybody.
And it will take 10 to 20 years for doctors to stop doing that.
Totally.
Which is mind-blowing to me. And I've investigated this with many people, including a friend of mine who used to be an OB, of like, I don't understand if your chief of obstetrics to me is a boss, right? That's what I always thought. Like, there's the director of maternal child health or whatever, or the maternity center, and there's the chief of OB. If they come out and say, you guys need to stop doing this, we need to get our rates lower, here's the parameters of where you can do the following intervention, then they should all be like, yes sir, that's what we'll do. And that's absolutely not what happens. Which
it's not, unless there's money involved, unless it comes from, like, one hospital that I worked at, we had a huge range of cesarean section rates. We had one doctor with like a 20% cesarean section rate. We had another doctor with like a 45% cesarean section rate. There was huge discrepancies, huge, differences in the practice. And they had been trying, quote, to get their cesarean section rate down for years and years and years. And it wasn't until insurance companies started decreasing their reimbursements for cesarean rates above a certain amount after the quality measures out of California came out a couple of years ago, that once the board was like, hey, we need to get our C-section rate down because we are losing money. That is what changed. And that it should actually not just be about the money. Like, it should be about like what's best practice for moms and babies, but I digress. We could do a whole podcast on that. So moral of the story is, correct. Providers are not always doing what's evidence-based. They are often doing what is culturally the norm at the place that they are practicing, or what they've always done because, quote, that's the way we've always done it, end quote.
So Emily, you decide, okay, fine, I'll get an epidural. I'm going to go in. So before we get to what happened, did you have an appointment with your midwives where you said, okay, yes, I'd like the version with an epidural, and had a conversation about that? How did that go as far as letting them know that that was the decision you made?
So I did not realize that that wasn't an option everywhere. And I had just, I think that same time that they had told me about the version, I had just booked the version because the timeline was pretty tight, and they told me, the sooner the better. At that point, I was 37 weeks. So getting there. um, and so I had not had a discussion with them about that. But when I walked in that day, I was feeling armed with some valuable evidence-based material, and feeling ready to kind of have this done, and feeling confident with the decision that an epidural would increase my chances and give me a better overall experience having to go through this version.
And we had talked about that too. We had talked about how not all places routinely do this, but that the place that you are having this version was a tertiary care academic medical center that had 24-hour in-house anesthesia and residents and plenty of personnel to do all of these things, so that, feeling, like you said, feeling really good that, even if it's not what their norm is, hey, I've got this information, and they have everything that they need to do it. It's not like a small community hospital who, there's some community hospitals where like the anesthesiologist isn't in-house. So you have to like go through scheduling to have them in-house and all of this stuff. So what was the version attempt like? Your first version attempt?
Spoiler alert.
Spoiler alert.
It was awful. I walked in there, and from the start, the vibe did not feel good. I was nervous, of course, having to undergo the procedure, but when I got in there, they were kind of just like whisking me one place and then the next. And I remember just trying to get a word in, like, like, can you slow down and tell me the process? Like, I'm feeling overwhelmed and everything.
And was your
they were just
partner
like,
with you?
yes.
Okay.
I had my partner with me.
Also is a chemistry professor, I should mention. So he's also a smarty pants.
And we had discussed all of the evidence-based stuff as well. And we also had a nurse midwife with us from the practice. And we had talked a little bit more that morning about, or when they got in as well, about the version. And that's when I brought up, so can I get an epidural? And she said, oh, I've never heard of that before, and we'll definitely bring it up. And so when the OB came in, and I had kind of a quick conversation, and the nurses there were like, nope, no epidurals. And I said, oh, well, why not? And they said, oh, we just don't do that here. So the quote, we just don't do that here.
Yep.
But if you
Which
were
is
in
funny.
labor,
I was just gonna say that.
If you were in labor, they'd be like, "Do you want your epidural? Do you want your epidural? Do you want your epidural?"
Like literally, if you
probably on the same floor as laboring people getting epidurals, right?
She was getting it done in the PACU.
Yeah,
she was getting it done in the PACU.
Yeah,
which is the post anesthesia care unit, which is on labor and delivery. Oh yeah.
Yeah. So they had said they didn't have it set up for me and all of that stuff.
Which is, again, the PACU is attached to the OR, which is where they give epidurals all the time.
By the way, they don't have to set it up. The anesthesiologist comes in and sets it up.
Yeah, right, it's literally like a tray. It's a tray that's the size of a cookie sheet. That's all they need to do an epidural.
An IV pole.
And an IV pole.
I mean, at that point, I had even said, well, if it's not a good time at this point in time, I'm happy to come back at a time that you can arrange it. And so I thought I was doing pretty good in advocating for myself at that point. And it just got completely shut down. And they said, well, do you want it today or do you not want one anymore? And we'll just schedule your C-section. And I said, I felt very cornered. I felt very belittled. And at that point, I me and my partner discussed it, and we decided, yeah, well, I guess we'll try it this way and see. Maybe, who knows, maybe it's a non-issue, right? So the OB came in, and he just kind of made things a little bit more worse. I may have pushed the buttons a little bit more by saying, there's accused me of essentially Googling online, and saying, you don't know what you were really reading. And I'm a researcher, right? So that was, but at the time I was just kind of so taken back by this exchange that was happening that I was silent. I couldn't defend myself. And I think about that all the time still, because I think about people who aren't researchers, who
Yeah.
just get told by their doctor or by their health professional that this is how it has to be done, and they say, oh, that must be true. And so it's terrifying to me.
There's a famous story of a famous author, childbirth educator, doula, international speaker named Penny Simkin, who you guys both probably know who she is. And there's a famous story of her getting in quote unquote trouble by a OB who worked at a hospital that she was teaching at years ago. And he called her up into the office, and I'm totally paraphrasing the story. I don't remember it exactly, but I'm pretty sure I remember the punchline. And he, discussed with her, like, I heard you said this, and I heard you said this, and what gives you the right to say these things? And she said, I can read. He was all like, what qualifications do you have, blah blah blah, because I'm a doctor, you know what I mean? And she's like, I can read. So as much as you're a researcher, like, in a way, like, you can be a quote unquote researcher who is just a person who likes to do research and who has read that this is what the information is. But I find it constantly fascinating, when you're in those situations where later you think, oh, what could I have said?
Oh yeah.
I'm sure you had that experience. But like, when he said the thing, or like, what are you Googling? Like, one of the perfect responses in my mind that pops up is just to be like, excuse me, you're a doctor of medicine? Well, I'm a doctor of chemistry. I have a clue how to do research just as much as you might, like,
oh, yeah.
Dude. But like, again, we don't have to do that. I have been the doula for doctors who are medical doctors, and they don't always, when they're in labor, they don't always speak up, like, because you're now a patient, you're a person who's in labor, you're a mother to be. Like, it's hard to speak up in that moment, no matter what.
It really is. I had a similar experience with my second, where I was a labor and delivery nurse. I also am a very outspoken person. I am a strong advocate. I have a lot of ammo, quote unquote, in my pocket of phrases to say in certain situations. And I found myself, really overwhelmed and belittled by this one particular provider who basically bullied me into an epidural that I then gave birth 10 minutes after receiving. So, because it's hard when you are the one that is the patient, or in labor or about to undergo a procedure, someone who has a baby that you want them to help protect, right? And it's like hard even you don't want to be in an argument with someone who's responsible for taking care of you and your baby, right? So you don't want people to, you don't want to feel like that. So okay, so this doctor is, who do you think you are, Googling stuff on the internet, and so then did you decide to just leave, or did you have the version, or what happened next?
So then I offered to email him the up to date, and
girl.
And he did not like that, and he had a room full of students, I should add. And his helper, and so I think at that point things had soured. Probably that was probably not the best advocacy point in my time, but
no, I disagree. I think that was pretty good.
Gives me a glimmer that I was.
But that's another thing that like adds to the layer of how fearful we can be to advocate for ourselves.
I know.
It's one thing if you just have a nurse in the room, then you have a nurse and a midwife, then you have a nurse and midwife and an OB, and man, then if the OB is bringing students with them,
yeah.
Oh, you've got a team of people, and you're like, "Hi, there's some evidence against what you're telling me." Like that's really hard.
Yeah.
It's super hard.
The professor, yeah, and then so then I he said, so are we gonna do this or not? And I was at this point crying because I'm feeling this way. And he said, not everything happens the way you want it all the time, and you're about to have a kid, and you'll learn that soon. Like, for example, you might have to cancel a vacation or a date night. You'll find that out soon. And then he proceeded to put my bed back so that I could have the procedure. And at that point, I kind of knew it wasn't going to work, but I also really knew that I'm the kind of person who would regret not trying every possible thing. And so at that point, I decided that I would try my best. And so him and one other person tried to turn the baby. I just remember a lot of pressure and a lot of pain and trying.
And you were also emotional, like you're saying, like you were like trying not to cry, trying in front of all of these people, feeling really cornered.
I remember shaking nonstop, and just feeling tense. I mean, how could I not at that point in time? So he tried a little bit. I think maybe like 1 or 2 times. He got maybe like a quarter of the way, and then the baby would just go back. So I don't remember exact details of how long he tried, but I do remember afterwards being like, nope, we're scheduling a C-section. So and at that point, I was actually also very upset with my nurse midwife because she was silent in the corner. And when I approached her about that, she actually mentioned he was like the head guy, the chief, and so she felt like she would have just been powerless anyways. But it would have felt really good to have her in my corner in the least.
Oh, that's so tough.
And there wasn't a conversation, or was there ever a conversation about trying to do a breech vaginal birth?
So they did not do that at that hospital. They did not feel comfortable with that. And I had said when they wanted to schedule the C-section that I really didn't feel like this was the best try we could do. And after the version, I did have a appointment a few days later with my nurse midwives. It may have been Melissa who encouraged me to do that, to talk to the midwives, if I remember correctly. That sounds right. And I actually, the nurse midwife that was there, I think she also felt badly about it because she took the time to meet with me and discuss it. But then we sat down for a decent amount of time and talked about possible options. We could try the version again, but like they had said, they just don't do the epidural there. And we had ended up scheming, I guess, that we would look up, and at this point, the nurse midwives did look up who would be on certain days. One, I did not want to see that other doctor ever again.
Sure.
And 2, I wanted someone who could give me a possible, good experience with a C-section should I actually need one. And before I decided to schedule a C-section with them, I said I really wanted to sit down or have a conversation or a phone conversation with the doctor who would be doing it. And we had said that in the conversation, I would ask if they would give me the epidural, try a version right then and there on the table.
Yeah, there you go.
Yeah.
Perfect.
And then if it was successful, then we would go from there. And I said, well, if it was successful, could I just say, I just want to be done? And they were like, no, you'd have to be induced at that point. And I was like, are you sure I'd have to?
Yeah, why?
Right, with this whole I have
point,
to.
Yeah.
Like, talk about lack of informed decision making.
Wow.
Like that they're.
Yeah.
But that's a good point too. That's another, for people who are having trouble finding a provider who, again, because the research does say that, yeah, that for those people who feel that the version wasn't successful because they had a hard time relaxing because of the discomfort, or just in general, doing an epidural with regional anesthesia has been shown to increase success rates. But let's say you had, wherever you are in the country, in the world, you're having trouble finding someone who will do that for you. If you're going to need a spinal anyway to do a major, the surgery, that is another option of doing the spinal and then trying to turn the baby. You are literally the most relaxed. You don't even feel pressure with the spinal, really. I mean, somewhat, but no pain. And a spinal, unlike an epidural, there's no tube in your back. So it's just a one-time shot. It's going to wear off in 2 to 3 hours. And so it's, even, not that invasive is the right word, but like it's even less, the needle they put in is even tinier into the space. There's nothing even that stays in your back. So when you brought that up, what did they say about they just said, nah, got to be induced if it works. And like, we're going to break your bag on the table and like force you to go into labor.
So at that point I had talked to the midwives and they said, well, we could discuss at that point if it was successful. But in talking to that, it was a woman OB who was going to try it this time. In talking to her, I didn't feel confident that it would be an honest attempt. It was kind of like, yeah, we'll appease you, is what it felt like in the conversation. And so at that point, I really did not feel comfortable with that. And so I actually said, well, I'm going to call you back. I'm not going to schedule it right this second. And I called Melissa and we chatted, and we both discussed, and I researched and she researched doctors in the area that could do breech deliveries and may possibly have a little bit more experience with that and with versions. And that's where I found the OB who actually delivered my son. And I remember having a phone conversation with him, and he was a very busy doctor, and he said, oh, I have 5 minutes for you. And I had a million questions, and I was like, oh, this is not off to a good start. But he was very reassuring. He actually had never done a version with an epidural either, but right then and there, he was like, oh, can you send me that article? Or can you send me that stuff? And so I knew then and there he was going to take it seriously. And then sure enough, at my initial appointment with him, which was at 38 weeks.
And this is a provider at a different hospital.
Completely different hospital, completely different state. Yeah.
Like an hour from where you were originally going to give birth?
It was probably like 35, 40 minutes or so.
So yeah, not too far, but definitely not as close as before.
And it wasn't a big academic medical center. It was actually a small community hospital. And this one doctor was just one of those old school docs that just, knows how to do things like forceps and vaginal breaches and versions, and has all those tools in his toolbox. And I remember talking to Emily about vaginal breach as just an option. And I remember you not really even leaning towards that, if I remember correctly. It seems like you're nodding your head, but I just mentioned it as the fact of, well, if you really want to be properly counseled on risk, benefits, and alternatives of, your options with a breech baby, then you should really go to see somebody who has done that before, because you're not going to get the same counseling, even if you ultimately choose, which you did, to not pursue that route of a vaginal breech birth. It's going to be a different counseling from someone who's done it before than someone who has never done it, is terrified of it, who, thinks that it's a terrible idea and has a very high cesarean section rate, So I gave you major props for that, because even though, some people might be like, well, I might as well just schedule a C-section. I would never want to do a vaginal breech. I think it was worth it to find someone who did it, just so you felt, like you mentioned, I wanted to know I had checked every box. I wanted to feel, however this pregnancy ended, that I had done my due diligence. And I think I think I was so proud of you.
Yeah.
I mean,
Yeah,
38 weeks to
absolutely.
be like, I'm going to go find another doctor because I remember like broaching this topic with you, like with like, I was nervous because,
Yeah. I don't want to offend.
well, Jeanette, you do this a lot too. You're teaching childbirth class, and like you
Yeah.
make this great impression on somebody teaching childbirth class, and then afterwards, like, I just have a question for you, and they come up to you, and they're like, or they stay on the Zoom call, I should say nowadays, but
Yeah.
they're like, so my provider, this is what I want, and my provider does the exact opposite, and then like, what is your advice? And you're like, like I just met you, but like, one of your options is not going to see that person anymore. Yeah. It's like kind of an awkward thing to say because sometimes people are like, oh, I can do that, and they're enthusiastic about it.
I know,
like
they're
you
like,
were.
yeah, but I'm 26 weeks. I mean,
right?
Can I do that? And you're like,
I had somebody in class the other day.
Much time.
I had somebody in class the other day who was 18 weeks pregnant, and she was like, what's the difference between a doctor and a midwife? And so I sent her some information. It was in a 3-week series, so I saw her again the next week, and she was like, can I change now? I'm like, oh my God, yes, you can. You haven't even had your anatomy scan yet. Like, you are so early in this process.
Yeah, I always talk about the woman that I know who switched care providers in labor.
Oh yeah, well, Christine,
different hospital because she was over 42 weeks, and her midwives had basically said, like, dude, we have to induce you. And one of the midwives made the mistake of saying, yeah, well, you're going to end up with a dead baby. Like some horrible way of saying something. Oh boy, yeah. Not a professional way of saying. She was like, forget that. And meanwhile, she had a doula who's also a midwife. And so she was still getting prenatal care from that person. She kind of switched roles with that doula. And anyway, she ended up showing up at a different hospital and happened to get an OB because that hospital doesn't have midwives, as it turns out. Happened to get an OB that was trained with midwives and who was actually really awesome about not judging her for being 42 and a half weeks pregnant and deciding to have an unmedicated birth. And she ended up having this beautiful unmedicated birth, and she went to labor on her own. It's just, wow. Like, she just showed up and was like, deal with me.
Yeah.
That's amazing.
I love it. So you meet with this doctor, and you have well, you had a phone call that was reassuring. You had a visit with him. How did you? This is the title of the podcast, right? Is firing your OB. People talk about I can't fire my OB. What did firing your midwife team look like? Was it dramatic and terrible with people throwing things? Like, was there a lot of confrontation and awkwardness?
It was super easy. Once I had a plan in place with my new doctor, I called them up and had my records transferred. I think I it's all a little bit of a blur because everything was rushing around. I can't remember if I asked for my records at the same time that I had my follow-up from my version, or if I had called up and asked for them. But I remember going in and picking them up, and it was a non-issue. It was just taking the records with me.
So there was no conversation face-to-face with the midwives that you've now decided to move on to another practice elsewhere?
I had left the midwives after my version and the plan to have the C-section version at that same hospital with the discussion that I was going to look into other possible places that would do a version with an epidural. At that point, that's what my kind of like drive was. And I think that's why they came up with the C-section epidural or the C-section version. But that wasn't appeasing enough to me, especially since I had that experience with the midwife sitting in the corner watching me go through what I had gone through. So I went to my new doctor and for a consultation, and like Melissa said, he ran through every single option in detail of what the possible risks were and everything. And then I felt so immediately so much more comfortable with the whole breech experience and I felt much more able to make an informed decision about how best to go about my birth, if I wanted a vaginal breech delivery or to go with a C-section should a version not work. He also was willing to try another version at 38 weeks with an epidural, and it, like Melissa said, it was a small community hospital. So I remember me having my consultation and him running next door, and you could actually hear through the wall, and he was talking to the hospital saying, I have this article, and this is like, he was like completely advocating, and I knew right then and there that it was the right move and I should have done it way sooner.
Oh, that's so sweet. Because like, again,
Yeah.
you know, sometimes we think like, oh, you know, that old nurse or that old doctor might be, you would be surprised. It's not about age. There are some younger doctors that are gung-ho about the evidence and or midwives, and there are some young docs and midwives that just like, you know, toe the line, and vice versa. There are maybe some old crotchety providers out there, but sometimes the gems are the ones that have just been around long enough to know that babies can come out, and you know, they've seen it time and time again. And so the fact that this doctor near the end of his career was like willing to advocate for you in something that was not a standard of practice there, that's really that is special. I was tickled pink to hear that. I was on the edge of my seat. I like literally remember like staring at my phone all day long to see if this version attempt had worked, because I wasn't with you at that time. You were with your husband in Connecticut. So all right, what happens? You go to the hospital, you're there. He's like, I have this research. They give you an epidural. Yeah. And then what happens?
Give me an epidural. It's just him and the nurses, who were also gems. And they were there was an air of excitement, I guess, for trying something new, right?
That's great.
And so they're like, ooh, this is awesome. And so everyone was like just standing there to see if it would work. They knew I had already had one failed attempt, and he was really focused, really into it. And I remember being like, wow, last time it was two people and they were just like almost aggressive, and he was very I mean, don't get me wrong, I felt pressure even with an epidural. It was not a comfortable procedure, but I felt so much more comfortable because he was like very meticulous and very particular about his stuff, and very cautious with, you know, checking the baby's heart rate and using the ultrasound as a positioning tool. But it took maybe 15 minutes. I remember it being pretty quick. I think it was like one attempt and then a second attempt, and the baby turned. So I remember there were cheers and tears.
And I actually remember you telling me the story, and you were like, he tries the first time one way to somersault, and then it doesn't work. And I don't know if you remember this, but you told me, I said to the doctor, oh no, it didn't work, did it? And he said, oh wait, no, I'm going to try again. I think I'm going to get it this time. Like he really was like, it's like he learned from the first attempt what to try and what, you know what I mean? Like you can really tell someone's skilled in that respect when he's like, okay, he's not going this way, but I can feel where he's at. I'm going to try to get him to go the other way. And so, yay, he turns, right?
I want to get you don't have to say it now, but I want to get this guy's name and have it on my little list of secrets, as long as
yes.
So and at this point, you know, we are expecting a baby that is similar in size to your daughter, who was about 7'10"-ish.
She was 7'10", yeah.
And so everybody's cheering, tears. You text me, I literally like burst into tears. Of course, I'm also pregnant and emotional, so I'm crying that this version worked. And so what was about your labor experience? You know, did they have to induce you right away because the version attempt worked at 38 weeks, or did you go home?
I went home. I got to take the morning. They ordered me a meal so I would regain some feeling in my legs, and then they sent me on my way and waited till natural labor started, and I was able to have my vaginal delivery like I had hoped, and it was a pretty good experience in the end. I was very, very proud of advocating for myself, and very thankful to have had a doula nurse in Melissa.
Yeah.
Because sometimes you need other people to help with the confidence to stand up for yourself, even if you feel it's right. Having the backup, even, I hate to say this, but even like my husband was giving me some confidence, but not in the same way that another third party could as well. So having the doula, having someone who is experienced in that really also helped. But just trying to find that confidence to
And
advocate was.
it's the it's the confidence building and the advice from someone who is knowledgeable. That's what makes a doula special. It's that, they know when the doctor says, well, that's just not done, or the midwife says, we can't do that, that they're like, well, 2 minutes down the road, they do it that way. Right. So, it's that insider info that you just don't know what you don't know when you're somebody who is having a baby, if that's not what live birth, eat birth, drink birth, sleep birth, like a lot of doulas and nurses do.
It's also fascinating to me, like the story of how they were, well, if we flipped him on the table right before the C-section, then we'd have to induce you. We'd have to have you give birth right then. Or if it doesn't work, we're doing surgery right away. And it's really fascinating because every other surgery that a person undergoes is either, I'm going to save your life with this. This is really necessary. And everybody's agreeing on this right now because it's really important. Or it's elective.
Right.
And you're like, maybe I'll have it done. Maybe I'll have it done tomorrow. It's not that bad yet. Or like, not necessarily like a nose job elective, which is an option, right?
Right.
But
But
even
like,
if
when
it's a
do I get
medical
my,
issue, it might
yeah,
be like, well, do we really need to do it this month? Like, I know I need to do it. It's a
I need
medical
to get my hip
thing.
replaced, but I'm going to wait till
Yeah, like
after
it's
the
all
summer.
elective, but in the world of obstetrics, it's not. Or we
It's
are made to feel that it absolutely is someone else's opinion. Nope, you're
right.
having this done now. Nope, you've got to have surgery. And it shouldn't be like that. And it's so true too, like what one doctor does. And even like, Melissa, like the one hospital you used to work at, that there's one doctor there that's well known for doing breech vaginal births
Mm-hmm.
and very high vaginal birth after C-section rates, and none of the other doctors in the same hospital do that the way that
Right.
he does. You're
Right.
like, here, I'm right here. I can show you how, Like,
Yeah. Right.
doesn't
No,
seem
it's
like there's
true.
an interest to be like, hey, how are you doing those good rates? Can you teach us something? It's
Well,
just
a lot
fascinating.
of hospitals, it's all private practices, right? So you might have the ABC group and the XYZ group and the 123 group, and they all have somebody that's on call from their group at the hospital every day. But those groups don't talk to each other. They don't share ideas. They don't do patient rounds with each other. They don't hold each other accountable. There's no like, hey, well, why are you inducing this person? This is a soft call. They are their own little islands. And I mean, this was when I worked high risk obstetrics in the city. We had 4,500 deliveries a year. We had like dozens and dozens of doctors, at least 10 practices of doctors, and none of them talked to each other. They all had totally different philosophies, totally different practices. Nobody was held accountable for anything.
And you've also told me the story of a recent hospital you worked at where there was somebody, I won't say details. I mean, I wouldn't say a name, but where something horrendous happened. This doctor was known to have done horrendous things before.
Mm-hmm.
Finally, I think, what did you say? Like got let go, sort of, or encouraged to retire, encouraged to resign, but then got hired by another hospital.
Yep.
And so their bad behavior, which was dangerous for the patients,
and everybody
well
agreed.
known to be dangerous to the patients, and apparently they did this at another hospital too. But like, this doesn't even go. So you can get hired by another hospital even if you're known to be dangerous.
Yeah. So even in your own hospital, like, some people might feel like, well, I don't have another option. This is the only hospital that my insurance takes, or this is the only hospital that I can get to for whatever reason. But know that, different practices have different practice philosophies. Let's say that your cesarean section rate at this big hospital for the hospital is a 25% rate. And that's one of the lowest in that area, right? that could be that some people have a 50% rate
Mm-hmm.
and some people have a 15% rate. And when you average them together, the hospital rate is 25%. So within a hospital system, there can be big differences in the way different groups practice. So don't be discouraged if you're thinking, hearing this podcast, well, another birth center or home birth or another hospital is not an option for me for whatever reason. Know that it's not uniform. Different private practices practice differently. So
you just said something else that's also really also fascinated me over the years, is that people, when they say, well, my insurance won't cover that. And I've definitely met people that because of wherever they work, they're only allowed to go to this one hospital, which makes me so angry. But anyway, but I think in our culture, because health insurance is a thing here in the United States, we don't go, well, hold on, how much would that cost me if I did have to pay for it myself? Because
True.
you might decide to spend, I'm not saying everybody can afford that, and I know there's lots of inequities and injustice and there's problems. However, in some situations, you might be in a situation where you'd be like, oh, it would cost that much? Well, guess what? Not having a surgery automatically is worth that amount of money to me, and I will pay it off on a credit card.
Yeah, or even more than that, I work in home birth now, and I've had a number of clients that we've taken care of that when they priced out their deductible plus their copay, it's equivalent or close to what a home birth would be out of pocket. So for some people, like, I can't afford that. Do you take insurance? I need to use my insurance. And then they actually look at their insurance, and the insurance is going to be a $2,500 deductible. And then they have to pay, 60% of the services or a 40% copay. And it's like, that adds up, especially if it's an epidural or a cesarean that maybe you didn't need, so definitely keep your options open. Sometimes we write things off because they seem inconvenient, they seem overwhelming, they seem confrontational, they seem expensive, but you would be surprised at how, at least in Massachusetts. I know people listen to this podcast all over the country, but at least in Massachusetts, you really have no excuse. I can drive from my house in Millbrae to the ocean in Boston and pass like 16 hospitals. So there's lots and
They're
lots
all doing
of
different
options.
things. So Emily, wait. So back to your birth. So how big was the second baby?
Oh,
9 pounds 4 ounces.
Nice.
A much bigger baby.
Yeah,
for sure.
And a pretty tough labor, like 17 hours of labor, and I think you push for at least a couple hours. And I remember thinking, oh my gosh, she's this poor thing. I had one moment of doubt, just one teeny tiny moment where I remember thinking, oh God, I convinced her to get this version and to cross state lines and have another provider.
Oh my God.
And then push for 2 hours after 17 hours of labor. And she's going to have a cesarean and she's going to hate me forever. And then I was like, I hadn't eaten anything in a while. I was pregnant. So I went out to get some peanut butter crackers. I was like, I will be right back. But I just shoved some peanut butter crackers in my face. And when I came back, the baby was crowning. And I was like, oh my God, thank you, Jesus.
I had more than one moment of doubt, but at that point, I would have been at peace with needing a C-section because I had done everything that I possibly could have done, and so that's all that I knew I wanted to do. So I wouldn't have hated you either.
Oh, thank you.
The other thing I was curious about with you is that you have now had the experience of at least having an epidural and having 2 unmedicated births.
Oh, that's interesting. Yeah.
How do you describe how an epidural feels just as a person who's not in labor? And kind of, do you feel like after you've had an epidural feeling, you know what that feels like? Did you think while you're in labor, like, oh, I kind of know what an epidural's like and I've had one before, maybe I should go for that again. Maybe I don't want this unmedicated birth after all because I like the epidural? Or were you like compartmentalizing it like that was helpful for that moment? That was fine. I don't want to do that for my birth. Like, can you share more about like what you think about that?
Yeah. So the epidural was a very interesting experience because I was like, oh, I've never had one, but now I can say I have with, also having natural unmedicated births. And it was a interesting experience for sure. I didn't know quite what to expect. It was a lot less overwhelming than I had anticipated because, you know, I had been so anti epidural the whole time, and now I was getting one for this procedure, and it honestly was not bad at all. I had a little bit of like hip pain afterwards, but you know, nothing bad. That could have also been from the version and stuff. But when I was in my labor, I was pretty focused. I had worked really hard to get that birth, and I also am somebody who likes to move around a lot in my labors, and so I did not want to give that part up. And so that was the big deterrent for me to not have an epidural, although it absolutely crossed my mind because I did need Pitocin to help my labor progress. And after that, that had absolutely crossed my mind, but I think at that point I was way too late.
Yeah, you had broken your water in the evening, I remember, and labored all throughout the night, and it was a hard labor with a big baby, and then we gave like a little whiff of Pitocin because you had done literally everything. I remember you were literally power squatting with your husband, like and lunging, and I mean, God bless you, because I was like, I was just throwing everything at you, and you did everything. Like you were in the shower, you were on your hands and knees, you were squatting, you were moving, just in so many. The only thing that I didn't have in my bag of tricks back then was my spinning. I wasn't as comfortable with a lot of the spinning babies moves as I am now. I was still fairly new to spinning babies. And so in hindsight, I would have done some shake the apples and maybe some rebozo belly sifting with you. But otherwise, I mean, you did literally everything. You needed a whiff of Pitocin. I think you had gotten up to like 4. And then you squatted that baby out, man. And we were all just shocked because nobody expected. I mean, that's another thing. The estimated fetal weight wasn't accurate. I think they had predicted
not at all.
No, not that big of a baby. And so, but you did it, man. Oh, and then when your husband started crying, oh my God, I remember the moment we were all crying.
He's like, oh, after all this we had to go through.
He just like, I mean, the baby's out and Emily's holding him and just, she's sobbing and then her husband, he's like hugging her and kissing her and talking to the baby. And then he just like lunged at me and like grabbed me and gave me this like big bear hug. He's like, thank you so much. Like, it was just, we had all been holding our breath for like 3 weeks, like, you know, and you had just done everything so much. Every wanted this so much for you, and you wanted this so badly. And you just, you did it. You did it. It just, it wouldn't have, and not that if you had decided at any point that you just wanted to stay at the other hospital and have a cesarean, that couldn't also have been a positive experience, because it certainly could have, but it just was so amazing to see, you know, to see you advocate for what you really wanted like that, and stack the cards in your favor. It was incredible. When I saw his weight, I almost passed out. I was like, what? That was just so cool. And you know, kudos to you also for staying unmedicated, because it was tough to get him out. And all those movements, you know, nobody has a crystal ball, but certainly couldn't have hurt helping to get him out. Absolutely. Squatting him, you know, to get him out when he was, you know, much bigger than your first, certainly didn't hurt.
So my question to you is, have you sent a letter to the previous practice and specifically to that doctor? And you are welcome to send him a link to this.
Yes.
Please go watch.
Yeah, I had drafted quite a few letters, and I don't actually remember if I sent it or not, because I don't think I had gotten it to a level to step back enough where I wasn't just completely emotional on the paper. And I definitely had a complaint filed through the midwife practice.
Good.
And they definitely acknowledged it. And I think I got a call from someone at the hospital and had to quickly describe my situation. But sorry, I think there's an airplane. Um, and then, but that was what I was able to do, besides replaying it in my head 1,000 times about other things that I could have said, for sure.
I think you're right. I think for a lot of people, you have to have time and a distance away from the emotion surrounding it to write that letter. But there's never too late to write it.
Well, and also writing a letter to the OB that ultimately was amazing, because as much as this conversation has been about firing your OB provider, you also hired another OB provider who ended up exactly what you needed and being wonderful.
Yeah, I was definitely thinking I should send him this link.
Yeah. He was awesome.
Send them both and see who you get a response from.
Yes.
I remember when you were pushing, he was just so calm. Like, he wasn't anybody that got rattled, and you were pushing.
Wait, so he
hard.
like specialed you so that he was at your actual birth too?
He was the only doctor that delivered at that hospital.
Yeah.
Oh, so you went from, but weren't you going, sorry, the first practice was a midwife and a bunch of doctors go, because it was a big teaching hospital. Okay, so you go to the small one, and he's the only OB anyway. Okay.
Yes,
okay,
right.
Cool.
So
wow,
yeah,
wow.
he was always on call.
Yes.
I don't know how anybody. He used to have 2 midwives working for him, I'm pretty sure.
Yes.
But then they, had left, and he was kind of winding down, his career, whatnot. I don't know. I don't know since if he's hired anybody else to work with him, but he didn't always work solo.
His son actually works with him.
Oh, okay.
Yeah.
I think I knew that.
Yeah.
So he was, I remember, like, you're squatting, like, you're working so hard. Of course you have all your power because you don't have an epidural. And I remember him sitting on the stool, and his hands and his like legs are crossed. And he's like, "So Emily, how hard, do you remember this? He's like, how hard did you have to push for your daughter?" And you're like, well, you tell the story if you remember it.
And I mean, you can probably tell it way better because I was crowning. So
he's like, how hard did you have to push? And you're like, really hard. And he's like, well, I think to get this baby out, you're gonna have to push harder than that. I just think it's gonna have to be even harder. And then like 3 pushes later, he's out, and he's 2 pounds bigger. And we were all like, it was just such a nice way, because so many doctors and even midwives, they put their fingers in someone's vagina, and they're like, how big did they say this baby is? And they're, well, oh, I don't, and it's like, that's so, just like deflates people's confidence. Like, well, this baby's probably bigger than your last one. So he never said that. He never said, this baby's too big for you, or I don't think this baby's going to fit, or you've been pushing for too long. It's your second baby. You've been pushing for 2 hours. Like, we're going to need to do a vacuum. He was just like, I just think you're going to have to push a little harder. And I remember thinking, because I had a baby at that point too, and I was about to have another baby, thinking, oh shit, he just told her to push even harder. Like, like I would have been like, I am pushing as hard. And you pushed that baby out. I don't know what strength. I can't even believe you had any strength left, but man, you did, and you found it, and you pushed him out, and it was amazing. Yeah. So what advice do you have for other pregnant people out there that might be listening and feeling unsupported or unsatisfied with their current care provider or anticipated place of birth?
I could go on forever talking about that, but I think that the biggest thing that I'd like to share is that there are other options, as we've been talking about all night. And there are people who will be willing to listen to you. You just have to find them, and don't give up your search until you feel comfortable. I also would say, try to muster the confidence to advocate for yourself. Doctors don't always stay up to date on everything that they should. And even if you don't have the resources to do that, you can, or as Jeanette said, you can find some resources, but also trust your gut, right? Like, there's something to be said about that, and a comfort level really helps with labor, and feeling comfortable will give you a better birth experience overall, I feel. And so advocating, not giving up to find till you find a doctor or a provider that you're comfortable with. And also, don't be afraid to ask questions, because I don't think that I asked enough questions to begin with, which is partially the reason why I had those fights with the first OB, because I didn't walk into the um, version knowing I wouldn't be getting a epidural. So,
What do you think, Jeanette? What advice would you give for somebody who is feeling unsupported in their birth plan
I mean, I
or their
love
place
that.
of
I
birth?
love what you just said. And going with your gut. I think too many times people who are expecting a baby are, being told by their partner or their providers, family, and friends, oh, it's no big deal. It's no big deal. Just get over it. All that matters is a healthy baby. And your birth experience does matter. And of course, we want a healthy baby and we want everybody in the family to be healthy. But your birth experience matters. And there are people out there who will do things differently. Even if, like you were talking about planning a C section, how do you line that up? Like if you end up deciding that a C-section is the best thing. I've been part of C-sections where we're like, ooh, I know some really cool nurses at that hospital. Let me call them and see if they're available for your planned C-section. So we
Sure.
know that there is a really cool nurse who's really going to help you get your way and make that a beautiful experience. So whether it's vaginal or C-section, figuring out, and I've known people who've switched hospitals to have a family-centered cesarean because in one case, because the midwives were they liked the idea, but they knew that that wasn't going to happen in their hospital. It does now in that hospital. Fortunately, that's changed a little bit, but yeah, it's a matter of seek, and it's never too late. I mean, most people are not going to have more than one or two or three kids, so each birth experience is super important. Then again,
Yeah.
there's always
I think those are
always that friend that has the well, I haven't seen her in forever, but who has 13 children and decided that for her last one she would have a home birth, and her 11-year-old caught the baby, and I just think it's such a cool story. And her first
yeah,
baby
right?
was born via cesarean, so
Oh wow.
she had
Oh
a bunch
wow.
of VBACs and eventually decided to give birth at home. And yeah, so she had a lot of options, of a lot of choices, but most people aren't going to have 13 babies. So yeah, good
That's
for
awesome.
you. I mean, it's a great story, and thank you for sharing it because most people don't know all the depths of those types of stories. They
yeah.
they don't. I think a lot of people. Melissa and I, we've gone to a lot of birth circles over the years, and that's a chance where people get to share their story. But in typical conversation in our culture, oh, how was your birth? Oh, it's good. Oh, the baby's here. Cool. Oh, did you go natural or epidural? Natural. And then it's over. Like there's not much more conversation
Sure. Yeah.
about the details of all the things you went to get that type of birth that you wanted.
Yeah.
So kudos to you. Awesome.
Yeah. If I
Thank
had
you.
any advice to people listening, it would be, well, two things. One, and I think you alluded to this, Emily, as far as trust your gut. When people show you who they really are, believe them.
Mm-hmm.
Right. So, when you had brought up that research, even if that doctor was never intending to do that, there is a bedside manner that can say, I hear what you're saying. I take your concerns seriously. This is why I don't feel comfortable doing that. And this is what I can provide for you. And but that's not what he did. He totally showed you who he really was and what likely you would, what type of experience you would have, whether it was a successful version, vaginal delivery, or a cesarean. Was that the culture was one where people didn't feel comfortable speaking up to certain providers, right? Like your midwife, who probably wanted to, but that's alarming to me right there. That she did
Right.
not feel like she could advocate for you. And number two, just being, I just love when he said to you, you're not always going to get what you want. Like one day you're going to, as a parent, you'll realize, and you're like, I already have a kid, dude. Like,
Yeah.
I have already lowered my expectations in life. Like,
Yeah.
But then the other thing I would say is consider remaining open-minded till the very last day and beyond. Once you have a baby, you should be open-minded. But so I've had people who strongly desire an unmedicated vaginal delivery, right? Like have gone through all the steps to achieve that, find out their baby is breech, go through everything to get the baby to turn, end up scheduling a cesarean, wrap their brains around a cesarean. They go to the hospital for their C-section and the baby is head down. And then they demand to have a C-section because they quote, already prepared for the cesarean. Do you know what I mean? Like, it's that short-sightedness that sometimes I feel like when we're just very end focused, like at this point, like I've already planned for this, right? I've already planned for the cesarean and wrapped my brain around it. I can't possibly, and you're like, wait a second, let's take a step back. This is major abdominal surgery. This is something that's going to have lasting impacts on your health for a long time. This is something you originally didn't want. And now the only reason why you're saying you want it is because it's a change of plans. So I would encourage people to remain open-minded. Like, I think what you said, Jeanette, was perfect. You might have chosen a hospital that had a very good family-centered vaginal birth experience that then you find out isn't going to allow skin to skin in the OR and routinely separates moms and babies postpartum. And so maybe you do switch to a neighboring hospital that probably wasn't going to be your best chance for an unmedicated vaginal birth, but it's going to do skin to skin in the OR and keeps moms and babies together, and all procedures are done in the room. And you know what? Hey, that hospital would be a perfect choice for that particular birth experience. So I would encourage people to, till the very end, keep an open mind. It's a great practice for parenting because you can't control babies and you certainly can't control birth. But thank you so much, Emily, for being here and sharing so much of your story. I know that it's going to help a lot of people out there who might be struggling, like you said, with that gut feeling that tells them it's time to switch, but they just feel overwhelmed by it. I also want to remind everybody, and I say this a lot, is that you only get to give birth to this baby one time. You could go on to have 13 children like Jeanette's friends, but you only get to give birth to this baby one time. And the way that you give birth to this baby can affect you physically and emotionally, mentally and spiritually for the rest of your life. It's not either or, a positive, empowering birth experience or a healthy baby. It can be both. Many people do have that. You don't have to accept less than what you deserve, which is both. So I hope you will join us for our next episode coming out after August 5th, and we will be discussing something on the other side of the spectrum, not birth, but breastfeeding, pumping at work, strategies for success. So we hope that you will join us for that episode.
Awesome. And everybody can see babiesincommon.com/show to see all our previous episodes and see what we have coming up. And the show is also available as a podcast on our website, Spotify, and Apple Podcasts. And please like Babies in Common on all your social media platforms and share anything that we post with your friends and family. Sharing is the most valuable on those social media things, as you might know.
Sharing is caring.
Sharing is caring in all sorts of ways. And always remember, Babies in Common is a community for you. After all, we all have babies in common.
Have a great night, everybody.
Thank you so much for having me.